Welcome. I'm Clint Lambert. I'm the host today of Village in Motion, and it is Tuesday, May 16th, and as I said earlier, it is only 6 weeks to the 4th of July. This morning, though, we have in the studio with us Anju Sharma, who is a physical therapist in our outpatient rehab here in Garden Ridge. Excuse me, not in Garden Ridge. Actually, you're down in Hunters Crossing, aren't you?
Hunters Crossing, yes.
All right, very good. Well, good morning and welcome, Anju.
Good morning, Clint. How are you?
Doing great. We're glad to have you with us this
Thank
morning.
you.
You've been here at Green Spring for how long?
About 4 years.
4 years, and you are a physical therapist.
Yes, sir.
What does that mean?
Physical therapist is somebody who treats physical dysfunctions using physical agents like electricity, exercises, anything that does not involve medication, basically.
Okay.
So changing lifestyle, stuff like that.
Okay. But it's not ECT when you say electricity is.
No, we don't zap people. No, it's to help ease up muscle tightness, pain, inflammation, and it's actually very soothing. Most people like that. We use heat with it, any physical agents that help to ease up the muscle tightness and pain, and then we give exercises to patients to do, and then we have home programs to follow up at home that patients have to do at home.
Okay. Do you do home care? I mean, you're saying you have home programs. Do you go into the home, or?
I usually the home therapy. We have a home therapy who go to home. So we have a whole group that works just at home with patients.
Oh, okay.
And in outpatient, we just see patients who come to outpatient clinic. And that's how it goes. And then we have Garden Ridge, of course, where skilled nursing, after patients have been in hospital, they go there for a little bit. And then they get better, they go to home, and then we have home therapy go there.
Okay.
And we have therapists to work for that. And then after that, if they need, they come to outpatient.
Okay.
Yeah.
And so the department in the lower level of Hunters Crossing
Yes, sir.
is purely outpatient then?
Yes, purely outpatient, yes.
Okay.
Physical therapy, and we have speech therapy there, and we have some occupational therapy.
Oh, all right, okay. Are you connected with Garden Ridge, with the physical therapy that goes on there, the rehab that goes on there?
Yes, we are same team, and we do help out each other at times needed. We just are dedicated to some people just primarily work at Garden Ridge, and like I primarily work at outpatient. But if needed help, we do go help each other, and so they come to help us and we go there.
Speaking of help, you are the only physical therapist in outpatients in Hunters Crossing, or are there others?
There are others who come from Garden Ridge to help, and then we have Natalie, who is our senior therapist now, who just started working with us. She used to be at Garden Ridge. She's full-time with us, but she does not see patients full-time because she has other admin work to do. So it's me and Natalie there, and then we have people coming from Garden Ridge helping us. But yes, as a full-time PT just doing patient care, I'm the one.
Okay. And then you have physical therapy techs also, is that correct?
We have one tech who helps us at front desk and making hot packs at times. So we have one person who's Karina, who's also new to our team. She started, I think, 2 or 3 months ago. I'm not sure, but around that.
All right. With the work you do, you've had to have a lot of education then, right?
Yes, I have a doctorate in physical therapy. Okay. Yes, I actually did 2 undergrads and then went for doctorate in physical therapy, and I graduated from Arizona with DPT.
Okay. So you're a DPT?
Yes, sir.
Doctorate of Physical Therapy?
Yes.
All right.
Yes.
Very good.
Yes.
Your education prepared you to do all the manipulation of the body then, right?
Yes,
From a physical therapy standpoint.
Yes, yes. We have to be, we do some manipulation working as what our physical therapy allows. We do that. So we use our hands, looking at manual therapy. We do that, and so it doesn't require any medication. So that's what we do mostly. We do use medication. Sometimes we have through with electricity electrolysis, or we call it iontophoresis, which helps in some localized tenderness, and we use that also.
Okay. Having gone to outpatient rehab a number of times over my 10 years here,
yes.
a lot of ultrasound I've received, and I have really felt like it's done great things for me
Yes.
in regards to it.
Yes.
Is that a standard procedure?
No, it's not standard. It depends on patient's needs. That's why we do evaluation when they come in first time,
Okay.
which is our longest session, as you know.
Right.
And that's when a PT like me, it determines if they need ultrasound, if that would be indicated for the diagnosis they come to see us for, and then we give it to them.
Very good.
Yes.
You just mentioned the initial assessment.
Yes.
And my understanding is there's some special requirements for who evaluates you for the initial assessment in regards to physical therapy.
For physical therapy, any physical therapist can evaluate you because we are all trained to do initial evaluation, but it has to be physical therapist.
Has to be a physical therapist.
Yes.
And that's a requirement by Medicare, correct?
Yes, mostly in general, everybody, everywhere. I think all insurances.
All insurances, okay.
And they go by Medicare, most of them.
Okay,
Yes.
all right. Your biggest workload is what? What do you treat mainly?
We see a lot of necks and back pains, arthritis, osteoporosis, which is our residents' primary dysfunction that we see here is pain. And also weakness, walking, balance.
Okay.
That's what we see a lot here.
What is the major treatment that you use for all those?
I mean, depending on the diagnosis, again, for pain, depending on the person, we have to also see their past history. So, though ultrasound could be good, but I might not use it for certain patient because of their past medical history.
Oh, okay.
So, that's why I have to do evaluation. So it depends on our evaluation what they need. We do ultrasound heat, electric stem, we have shortwave diathermy, any of those, and of course exercises have to be done because to have more carryover, exercise is a must. All these things help temporarily, but then if exercises are not done, the carryover is not going to be good. So it's temporary, and then they're going to be back to square one. So exercise is with us, and then at home, and then we do exercises every time they come with the treatment, what's needed, and we teach them sometimes their posture. So we have to give them exercises for posture to correct it, and also to make sure it doesn't regress anymore. So we have to see a patient as a whole unit and what's causing the pain, and that's how we treat them.
So what I'm hearing you say is it's really important to continue to do the exercises that you instruct patients to do.
Very important. Very.
Okay. Forever, or is there a time limit?
Sometimes forever.
Oh, okay.
Yeah, if they have arthritis and that's causing pain, we can help them with pain at that time. If they don't do their exercises, then the arthritis is going to start acting up again because arthritis doesn't go away.
Right.
So it's going to start inflammation and pain again. If it's their posture, if they don't do their exercise, that posture is going to start that pain again.
Okay.
So everything has to be kept in control.
Right.
And that's exercises. Yeah.
All right. I know that you are certified to do a special thing in regards to physical therapy. And what is that?
That's the LSVT program for our, we call it BIG, for Parkinson's disease or it's a lot of neurologically based neurosensory motor conditions that it works for.
LSVT?
LSVT.
All right.
And that's the program. It initially started for speech, and that is the LOUD program. And that is all done by a speech therapist, and we have Heather who does that over in our department, and I just recently got certified and just started seeing some patients.
Congratulations.
Thank you. Thank you.
You also do a program called BIG, right? B-I-G?
That's LSVT, BIG.
Oh, okay.
So LSVT is loud and big. Loud is for speech therapy, and big is for the limbs, mostly the motor sensory or motor control.
Okay. And what does that involve?
And that involves for big, I can say loud is mostly for speech because we primarily see Parkinson's patients here, and the voice gets lower and lower. You can't hear them, and so loud working on the amplitude of and treatment of the motor muscles connected with speech. And we, as big as therapists, and that could be OT or PT, anybody could do that.
So the loud part focuses on increasing the amplitude. Okay.
And the voice.
And
yes.
the voice. Okay.
And big concentrates on the limbs primarily, the motor control of the limbs, because that's one thing also gets affected by Parkinson's, because it affects the posture, and they don't move limbs through the proper range, so it has to be moved through higher range or more range, because the posture goes more in flexion, and the arms are not moving. So we teach them how to incorporate the high amplitude of use of the limbs along with the functional activities to help their walking and doing the daily stuff.
Okay. How do you do that? What do you do to?
We use exercise program which is very intense, and we work with them 1 hour for 4 days for 4 months. So it has to be, it's 4 days straight. We work with them, and during that 1 hour, it's intense. We just don't give them too many breaks. This is exercise. We have 8 exercises, which include sitting exercises, standing, rocking, which helps in stepping, higher stepping, and helping them to control their body and limbs better to walk and do functions like transfers. And then we work on some functional activities like sit to stand, which is primarily affected also for transfers and affects their balance and falls. And then we also work on things like getting inside things that affect some people if they're having problem with getting in and out of car, we work on that. Some people are having problems getting in and out of bed, depending on some of them are the initial stages. So those kind of activities we work with them. So we repeat them 5 times. We do at least 7 exercises, each exercise 8 to 10 times during the session. And then we do sit to stand. We do walking for 15 minutes, where we work on this increased amplitude of stepping, because that gets affected. The steps get shorter, and that makes them fall down. So we work on that, and then we also work on the activities that are affected, like buttoning, writing, or getting in and out of bed, stuff like that.
So 4 consecutive days for 4 months.
4 weeks.
4 weeks. 4 weeks.
So 16 sessions.
16 sessions.
Yes.
That's a lot of work.
Yes.
But it sounds like it's very effective.
Yes, it is very effective, and then they have to continue with those exercises again. The days they don't come to see us, at least half an hour of those exercises, we give them pictures, everything, and then they also have to do that after they're done with us. They have to continue. If they don't continue, then of course the disease process takes over, and they can regress. And it's a lot of people come every year or every other year just to kind of refresh, to get started on that.
Very good. Very
good.
All right. What I'm hearing then is it's actually very, very important for all of us that we make sure that we do the exercises that we learn in regards to it.
Yes. I think that's the most important thing, to have a better carryover. Therapy can work only if the exercise program at home is carried over. Okay, very good.
Anju, we're so glad you came to be with us today. And,
my pleasure.
You have shared a tremendous amount of information.
Thank you.
And watch your schedule. It may get totally jammed up.
Yes, pretty jammed up. Yes.
Very good. Very good. Well, thanks again. We look forward to you being back with us.
Thank you, Clint.
My pleasure.